Okay, so welcome everyone. We're super lucky today to have Dr. Harry Hu. He's from the University of Colorado Anschutz School of Medicine. He did his PhD in Mayo in Minnesota, I believe, and has been at a number of places, as we were just saying, Hyperfine recently, but now he is a professor at the University of Colorado. He's going to be talking to a topic very, very near and dear to my heart, namely parallel imaging, which is a technique in MRI that you guys will be hearing a lot about over the coming 30 minutes or so. So uh, without further ado, I'll hand it over to Harry.
Awesome. Thank you very much for the introduction. Just let me know if you can hear okay and see the slides okay, and I'll try to monitor the chat window, but anyone can cut me off with questions as we go along. So I'll be talking about parallel imaging. Probably you have heard of this if you've done any MR. Um, Today we're just going to have a brief introduction. This is a topic I'm very close to just because I also did my PhD, like Joe, on parallel imaging back in the early 2000s. So it's nice to see something of a technique that starts out as an idea and ultimately makes it into a full-fledged commercial product. My email's here. You can always reach me. I know Joe's recording, so not a big deal. I'm going to share these slides too, but these are also online, so you can always go back and download the slides. And I have some reference materials there as well. Okay, so not going to go through all of this. I'm barely going to touch the surface of this topic. There's a ton of reference materials out there. Most of these are in the Google Drive that I'm going to share with you. So just have a look. The whole point here is this is a very mature technology now. It started out in the early 2000s. And now when you go buy an MRI scanner, parallel imaging techniques are already put on the scanner as part of the commercial product. Okay, so I have a couple of learning objectives. I have very few text-based slides, many are images, so this will be one of the few text-based slides. I'm only going to talk about parallel receive imaging today, and I'm going to largely focus on the image-based methods, aka also known as sensitivity or sense on the Philips systems. There are a number of K-space-based methods called GRAPPA. I'm not really going to talk about them just because they're a little bit harder to visualize on a set of slides, and the image-based methods make a lot more sense. No pun intended there. There is a totally separate topic called parallel transmit imaging as opposed to parallel receive imaging. That's also not the topic of today, and we can fill up easily another lecture, an hour lecture just about that. So if you ever heard of things like simultaneous multi-slice imaging or multi-band imaging, that's all parallel transmit techniques. And the goal of those is to improve B1 transmit homogeneity and reduce dielectric effects. We're not going to talk about that today. We're only going to talk about parallel receive imaging. Okay, so with parallel imaging today, I'm going to do a few specific things. I'm going to demonstrate to you, and hopefully you already know this a little bit, the important role of coil arrays, receive coil arrays in parallel imaging, to understand some of the benefits and trade-offs of signal to noise ratio when you do parallel imaging, and to understand most importantly for any MR technique, what are the common artifacts that you tend to encounter when you do parallel imaging when things don't go the way you expect them to. This is a pretty busy slide, but I thought I'd just show the three most common vendors and what their screens look like. So if you ever use Siemens MRI system and you go to the resolution tab of any image and you pull it down, you'll see things like Grappa or Kuiperina. Those are all parallel imaging techniques. If you're on the Philips system, you go to the geometry tab and you can see here the sense option is click to no, but you can click it to yes and determine how much acceleration you want. On GE, you can go to the acceleration tab and you can pick the level of acceleration you want. And GE has different methods for parallel imaging called ASIC or ARC. These are all acronyms, but they essentially do the same thing. So the main thing to point out again is that this is a very mature technique, and parallel imaging is ever so common now on many protocols. And by virtue, many default settings are actually turned on. So parallel imaging is already working in the background, regardless of whether you actually know it or not. Okay, so the basic premise, just to start off, we have MRI. The whole idea is that we have RF transmission going into the system, into the body to excite the magnetization in your body, and we have RF receive, which is coming out with the signal as the magnetization relaxes. So this is the big picture. And you all know that for brain imaging, you probably have seen the most basic transmit receive or TR, and this is a single channel coil, and basically one channel gets you the entire image. But nowadays, when you go buy an MRI scanner, the TR coil, the transmit receive coil, is almost never used, and rather you have all these potpourri of multiple coil channel receive. So this, in case here, is a 6-channel receive coil, but you can go anywhere from 6, 8, 16. There's even 40 some channel coils on the market today. And the whole point is that each coil element then takes only a part of the image or is only sensitive to a part of the image. And that's the basis of parallel imaging. So if you were to kind of write this out and forget the plot on the lower left here for a second, you basically have image for a particular coil with the index K. This could be any number of these 6. And it's essentially the object multiplied or weighted by the coil sensitivity profile for that Kth element. And you can measure these sensitivity profiles later on. We'll talk about how, but you can measure them. You don't often see them on the scanner, but they're measured behind the scenes, and they're usually low resolution images. So here is just 2 examples. One with a sensitivity that's very high on the left side of the image, and one that's very sensitive on the right side of the image, and the sensitivity dies off. So that's the point of the plot on here. You can see that for a single channel body coil or a single channel head coil, their sensitivity is uniform as a function of distance. But as you go into smaller coils with a radius of 6 inches or 3 inches, the smaller the coil, the bigger the diameter, the bigger the sensitivity drop off you can see, because the smaller the coil, they're only sensitive to the, what's close to the coil. As the distance goes away, the sensitivity dies off. So it's essentially how drastically the sensitivity profile falls. So just to keep that concept in mind. And then just to get the terminology correct, again, we often don't see the individual coil images in packs or as they come up on the scanner. What you ultimately see is the root sum of squares image, which is combines all of the coil elements together. But it's the individual ones that we take advantage of when we do parallel imaging. So parallel imaging reconstruction, this is the 50,000-foot kind of bird's eye view. All we're trying to do is we're going to try to cheat K-space, and we're going to subsample it. And by subsample it, we're going to alias. And with parallel imaging techniques, we're going to try to unalias or unwrap the image. So you start off always with sub-encoded K-space. Here is shown for the Cartesian version. We have fully acquired lines that we acquire with the solid orange arrows here, and we're actually purposely skipping the dashed phase encoding lines because we're trying to save time. And if you do a Fourier transform, you get an aliased image because the field of view is too small and you violate the Nyquist theorem. And then with the sensitivity encoding methods or sense, we go through image space and we try to reconstruct the image. And I'll explain how we do this later, but the finish line is the fully encoded image, and we show a phantom here. So again, remember this equation: image coil is equal to the object weighted or multiplied by the coil sensitivity profile. The other way to do it, which is what I'm not going to illustrate, but of course Joe is the expert here on this. This is the K-space basis methods, originally called SMASH, but now more commonly called GRAPPA, from the Siemens manufacturer. We actually try to reconstruct the K-space, missing K-space lines first. So by going through the reconstruction of K-space first before taking the Fourier transform. So which path you take doesn't really matter. The math is relatively the same. It's just whether you do it in image space or in Fourier space. In Fourier space, however, I just want to tell you that rather than multiplication in Fourier space, it's a convolution. And this is why it's a little bit harder to kind of visually see this happen in K-space. But just remember that we're no longer multiplying, but that the Fourier transform of the image of the particular coil is the object itself convolved, not multiplied, but convolved with the Fourier transform of the coil sensitivity profile. So the math is the same, it's just in a different transform. All right, let's focus a little bit more on sense. I'm going to show this later again, but these are your take-home points for today. So parallel imaging, if you don't already know, is universally used. It is a fundamentally technique that acquires fewer phase encoding data of lines in K-space. That's the basis. And by doing this, because we're acquiring fewer lines, we have shorter scan time. And shorter scan time can benefit everyone, from reducing motion to having shorter breath holds and things like that. Some of the things that we didn't realize initially with parallel imaging, other than shortening the scan time, is that you can also use it to reduce certain pulse sequences that have a long echo train length. And so those are the fast spin echoes and the echo planar imaging sequences. And of course, when you have a reduced echo train length, you start to minimize air tissue or implant susceptibility, geometric distortion, and things of that sort. And this all boils down to, we're acquiring less data, we can achieve a shorter scan time and a shorter echo time, and we can also have reduced T2 star blurring across the echo train. I put some references here in case you want to look up some more examples. I'll show some examples, but I don't have time to show everything. And the last thing is, from the technologist point of view, if you're sitting at the console, often when I teach this to the technologists and the residents and you're trying to do protocol optimization, parallel imaging gives you that extra knob of flexibility. It allows you to balance your acquisition time, your spatial resolution, and your temporal resolution if you're doing a dynamic scan, and your SNR and your image quality. It's an extra dimension that you didn't have before if you were just using a single coil. And often it'll allow you to achieve one of these nominal values that you're desiring that you otherwise couldn't. All right, so this is what you need to remember. Parallel imaging can be, I can't actually think of a pulse sequence that it can't be applied to. So it can be nearly applied to all pulse sequences. The theory says it can, and it probably can. R is the reduction factor, or AKA the acceleration factor, also known as the acceleration factor. We often denote R just by R, but if you're doing one-dimensional phase encoding, in 2D MRI for acceleration, but you can accelerate 2 dimensions along the phase and slice encoding dimension. So in papers, you'll also see that it can be split into an RY and an RZ for the 2 different locations. At the end of the day, you just need to remember that parallel imaging exploits the coiled arrays and their spatially varying sensitivity patterns for data reconstruction. This is very important, because if the sensitivity patterns don't vary enough spatially, then you'll get artifacts. And we'll talk a little bit about what's called the geometry factor, which is how you can quantify how well parallel imaging is working. Again, that's something you don't always see on the vendor scanners in PACS, but hopefully you'll see some intuitive examples here. Okay, so I've shown you this, and all we're going to do is we're going to use the spatially varying sensitive patterns to estimate or fill in the K-space that we skipped. So that's the overview take-home message. A little bit of a tour back in history. Joe and I were just talking about this before the session started. I think this all goes back to the 1990 paper by Pete Romer on phased array coils. It was in the 1990s that people thought that we can build coils with different elements. So here's the original 1990 Pete Romer paper with a 4-element array. Image encoding or sensitivity encoded parallel imaging was published in 1999 by Klaus Prusman from Zurich. And then the K-space methods were published later in the 90s, 1997 by Dan Sodikson at Beth Israel, and then Mark Griswold in 2002. There's Mark there in 2002 at the time in Germany. So there are many, many different acronyms. So depending on what vendor you work on, they have commercial kind of trademarked acronyms, but at the end of the day, they point to either the sensitivity encoding method or the case-based GRAPPA methods. Okay, so this is a teaser. I don't tell you which one is which, but in each of these paired images, one of them is acquired with parallel imaging and one of them is acquired without parallel imaging. I'll just give you 5 seconds so you can, there's no trick question here. You can probably guess which one is which. So in all of them, the one on the right is the one that's acquired with parallel imaging. You can obviously see that the pulmonary vessels here are sharper due to a shorter breath hold. Angiography, contrast enhanced angiography vessels are a little bit sharper with a shorter breath hold. Down here is a diffusion weighted scan with EPI distortion. you can see that the geometric distortion at the front lobe and the temporal lobe are lessened with parallel imaging because of the fewer or the shorter echo train length of the EPI sequence. And then overall, just a slightly better image quality and sharpness with the shorter scan time. Okay, so I already mentioned a few reasons, but let's go through why, all the reasons I can think of why you want to image faster. We talked about reducing motion. We talked about improving or trying to get faster temporal resolution if you image something that's moving. It could be a dynamic phenomenon such as contrast, gadolinium contrast coming into the blood. Inherently long scans need to be reduced. Of course, that goes back to motion. If you have a patient that's non-tolerant, like a pediatric patient or someone who just can't stay still without sedation. Um, by the way, if you follow ISMRM or the Journal of Magnetic Resonance in Medicine in 2014, there was a large community survey asking what were the top 30 papers at that time that shaped the field of MRI, and parallel imaging, you can see, is one of them, and so is transmit parallel imaging. So just to give you an idea of the kind of the stature of the techniques that we're talking about. And you'll notice that Pete Romer's paper on phased array coil is also on the list. Okay, so obviously we also want to go faster because you only have a certain limited time to acquire something, and this could again be contrast enhanced MRA, where the gadolinium T1 shortening effect only lasts so long, or if you're trying to capture blood that's flowing in that's enhanced. And of course, long scans like repetitive scanning, fMRI, DTI, things like that, you also want to make as short as possible. And if you're using EPI sequences or fast spin echo sequences, you reduce the distortion and the T2 decay along the echo train. Okay, so just to kind of set you into the pulse sequence diagram kind of things, you all know from the traditional MR technique that we are slow, that we acquire K-space line by line. This is the original spin warp technique, and the acquisition of one slice is equal to NY, which is the number of phasing codes, times the TR. Then this was the original idea by Paul Lauterbur. Fast forward a couple of years, and you now have the fast spin echo, or previously called the rare technique, coined by Jürgen Hennig. And here, rather than a single line, we acquire multiple lines per TR. So now we have this term called the echo train length, and this is shown for an echo train length of 3. So now the number of shots is equal to the phasing code divided by the echo train length, and you can go faster in scan time. We're showing here in 2D, but just remember in 3D, you have an extra dimension NZ, which is the number of slices that you have to encode as well. And that costs you some TR or some repetition time. Moving even faster, we can go to the single shot fast spin echo technique. So rather than the original one where we're only acquiring one echo, or the fast spin echo, we're acquiring an echo train length of 3. Now we have the fast spin echo single shot fast spin echo technique, where we acquire all 180-degree phasing codes in a single TR. So this is super fast, even without parallel imaging, and we use it a lot in the abdomen or in fetal imaging. And you might know this as HASTE on the Siemens scanner, or SSFSE on GE and Philips. So these are all ways to go fast. And then even further, we have EPI. So this is coined by Peter Mansfield, and the pulse sequence diagram here is not too important. It's just to show you how the gradients play out with the trajectory of K-space. But the idea here is that you raster through K-space back and forth, back and forth, back and forth in a single TR. So T2 star decay is actually occurring along the echo train. And you can have a spin echo based EPI or a gradient echo based EPI. Okay, so then in that case, what else can you do if you want to go faster? If you're not using some kind of pulse sequence or K-space trajectory trick, in that case, you can only reduce NY or NZ by, you can't change TR because that controls your contrast or your tissue contrast. So you're going to reduce NY and NZ. And so come the early 2000s, we now live in the world of coil arrays. So we're often taught in MRI that there's only one major RF coil, and that's the one that's in the magnet. And that's true, that's the body coil, transmit and receive coil. But you know now that when you go buy an MRI scanner, you have the option to purchase many different extremity coils and phased array coils that are contoured to the body part of interest. So you can just see different ones being showcased here. And all these will be useful for parallel imaging, and not only for parallel imaging, but also for improved signal to noise ratio. And that's shown here. You can see that with the scanning of my leg, you get a very noisy image, but if you put a 4-element surface coil array on it, the SNR gets better. Otherwise, the anatomy and the image contrast looks the same. So that's where the parallel term comes in. We are measuring the signal in parallel through different coils, and so each pixel in that anatomy is picked up by 4 different coils in this case, and you see the sum of squares, and it's picked up by the 4 different coils in parallel. And each coil is sensitive to a particular region of the image with differential sensitivity. So in essence, every coil in the pulse sequence acquires its own K space, and you'll get your own image, and it's the weighting of the sensitivity areas, the extra information that's exploited. Okay, so coil geometry is important. You'll hear me say this a few times throughout the lecture. It's fairly intuitive to think that if you want to scan any body part, that you'll want the coil geometry to have a circumferential coverage of the body part, and that does make sense. So you can have a setup where the 8 elements here cover the head circumferentially, where you have 8 elements here around the body that cover circumferentially, and you can tell that each element pretty much has a unique sensitivity either in the right, left, or the anterior, posterior direction. That's not always true, and I just show a good example here. Very often now, we often have coils that are in the spine. So there's 4 elements here in this particular spine that's in the table C1, 2, 3, 4. If you pay attention to how the signal is acquired, you can see that there's good sensitivity of C1, C2, C3, and C4 along the SI direction, or the superior inferior head direction, but there's actually no sensitivity profile or difference along the left and right direction. And you'll see later that if you were to do sensitivity encoding or parallel imaging here, left and right direction is not the best direction to pick because there's no sensitivity difference left and right, and it's the foot head direction that's actually the one that you want to take advantage of. So just be mindful sometimes when you do parallel imaging and the anatomy you're interested, what coil you actually have plugged in. Okay, so we've seen this many times before. We're going to cheat K space on the bottom, and by cheating K space, we consequently suffer from aliasing. And these are the aliasing or the wraparound artifacts that we're going to reconstruct. But in doing so, we are able to accelerate our imaging time by a factor R. In this case, it's an R factor of 2. You don't have to do an R factor of 2. You can do an R factor of just about anything. It just so that the phase encoding number that you acquire eventually is an integer. I don't think you can acquire like a decimal point phase encoding. So you can see a full field of view image, and you can see that by doing 2.56 acceleration, I actually fold or alias a little bit more, and then by pushing the acceleration higher and higher, the object is folding in. It's like folding a piece of paper, it gets folded more and more. And eventually with R equals 4, you can see that any pixel in here is actually the superpositioning of 4 other pixels in the original image. So just keep in mind that R doesn't have to be an integer number. It could be any number up to some limit, and we'll talk about that limit in a little bit. So like I said, it is a lot like folding a piece of paper, but it's a little bit deterministic, at least in Cartesian K-space MRI that we've been talking about. And so for this particular image, the aliased image, the red dot or the red pixel is actually a superpositioning of 3 pixels in the original image as I've shown here. And the area where the green circle pixel is actually a superpositioning of 2. So that's just help you to kind of visualize what's going on. But at the end of the day, just remember that each coil element has a different signal sensitivity at each of these 3 locations or 2 locations. And we're going to backtrack the aliasing effect. We're going to take this resulting aliased image, and we're going to figure out how much contributions came from the individual pixels on the original image. So the next few slides are a little bit technical, but I think hopefully graphically you'll understand what I'm talking about. Coming back to the original phantom, I have now pretend I have a coil on the top and a coil on the bottom, and that's obviously what we want, but that's not what we get. What we get is the alias image because we're cheating K-space for an R factor of 2. I will talk about this later, but we have for now, just know that we have some predetermined coil sensitivity profiles, and you can see that I've measured the coil sensitivity profiles along the object, and you can see that the top coil has high sensitivity on the top, and the bottom coil has high sensitivity on the bottom. And then we can do a little bit of mathematical expression. We can relate the pixels that we want in green to the pixels that we want in A. And how we realize is that for a particular pixel, let's say P of M, it is actually seen by the two coils differently. It is actually seen as a dark pixel on coil 2, and actually as a bright pixel on coil 1. So these two curves represent figuratively the two coil sensitivity profiles, and you can see that they're quite different. And you can see that for pixel N on the bottom, they're quite different as well. The closer these two plots get for a particular voxel, the harder it is to do parallel imaging. So we can then relate this. This is purely linear algebra. The aliased image voxels that we get is a summation of the two pixels in the original image, followed by their sensitivity profiles. And you can write this with a little bit of bookkeeping for every coil you have. And at the end of the day, you can see that this is just a matrix algebra, and this is what the scanner does for you in the background when it acquires parallel imaging data and tries to reconstruct. You know what A is, you know what S is, and what you're trying to do is solve for P. And in order to solve for P, you need to invert S, so this becomes a linear algebra problem. And so in order for S to be invertible, the sensitivity profiles have to be quite sufficiently unique and different, or else the S matrix becomes non-invertible. So I've shown you a little bit of the math behind this and how invertible the S matrix is essentially termed together into what's known as the geometry factor. Here I've shown you the reconstruction. This is actually from my PhD days, and you can see that the image that's acquired on the left with half the scan time is nearly indistinguishable from the body coil reference image. You can see that there's no aliasing artifacts. And when there's no aliasing or residual artifacts, then the inversion or the geometry factor is a perfect. So the sensitivity profiles were adequate. And you'll see later with examples that the aliasing is not always perfect. Okay, this is very busy. It's not for you to remember, obviously, but that in essence, this entire process can be generalized. You can obviously have more than two coils. And so this just becomes matrix algebra, and it all inevitably depends on how well you can invert the sensitivity matrix, and this comes back to coil design. So again, coil geometry is important. How do we actually compute the sensitivity? This is actually something you, if you're sitting at the scanner, you don't always see, but the scanner is acquiring this data in the background. And so we're acquiring low resolution images, and then we're normalizing them by the sum of squares image to get the sensitivity profiles. And these are sitting in memory in the back. So here's just an example in the previous phantom. Here's an example in the previous spring that I showed. And often there's some smoothing that goes on to fill in some of the noise. This is a screen capture from a GE scanner. If you're ever on a GE scanner and you'll notice these calibration sequences, they're put in automatically when you do a protocol. That's actually the sense coil calibration scans happening in the background. When you actually scan these, nothing comes out on the scanner. You actually don't see anything, but the data is there. So that's how you know that the parallel imaging is working. We've only talked about 1D sense so far, and I've illustrated 1D sense. I'm only going to show one slide here to tell you that sense or parallel imaging can happen in 2D. And now it's a little bit of a visual challenge, but you can still visualize that a particular pixel is now not just folding or aliasing in one direction, but it's actually folding in two different directions. So I've tried to illustrate that for you here with the phantom again, where the image on the bottom right corner is actually superpositioning of 3 other pixels, or 4 other pixels if you count the original one, but the 3 other pixels come from 2 different dimensions. And if you look into the literature, there are many ways now. Now you have even an additional dimension of flexibility. So if you want to accelerate in 2 dimensions with a 2x2 factor, you can be the simplest as possible and just skip every other 2. or you can actually shift the acceleration as you see here for the Siemens Kuiper technique. And the advantage of this, as you'll see in the image below, is that rather than superpositioning a particular slice on top of another slice with conventional skipping, by shifting, you actually shift the other slice that's aliasing to the outside of the field of view. So actually, the acceleration is the same, but the amount of pixels that's aliasing is actually fewer. So there's fewer, if you will, pixels for you to unalias or solve. Again, this is not too critical, but just to realize that some of this is happening in the background depending on what parallel imaging technique you picked. Okay, so let's just talk about the geometry factor for a second. I said that coil geometry is important and is ever so important. Parallel imaging comes at a cost. It comes at a cost of SNR because you're acquiring data faster. And because you're acquiring data faster and spending less time, you're going to inherently lose SNR by a factor of square root of R. And so if your R is equal to the square root of 2, a factor of 2, then you're losing SNR by a square root of factor of 2. There's this additional factor called the geometry factor, and this is how invertible that sensitivity matrix is. And this is from the literature. You can see that for either SENS or GRAPPA, this is the geometry factor from 0 to 2.5. 1 is actually ideal, and you can see that the faster you go, or the faster you try to cheat K-space and try to accelerate, it is more difficult to unalias or reconstruct the image. And often it is in the middle of the image where the coil sensitivity profiles are the least different. So here you can see in the middle, there's a G factor of about 2.5. So in addition to the native loss of SNR due to acceleration, you're losing an additional 2.5 fold SNR because of the geometry. And this is purely the inability or the lack of ability of the coil sensitivity profiles from the different elements to reconstruct or unaliased image. And again, in the in vivo examples I'll show later, you'll see that you often see image artifacts in the middle. So here are some G factor maps for 2D acceleration on an 8-channel coil. So you can see that the faster you can't go as fast as you want. You can only reasonably accelerate 2, maybe 4, until you get to an overlap where it's nearly difficult to resolve it. So you can see for factors, acceleration factors of 6 and 8, the geometry factor is already getting pretty high. So you can see for the acceleration factor 8, this is a non-diagnostic image. Even though the algorithm worked, it's too noisy, and this is an explosion of the noise amplification due to poor geometry factor or poor coil geometry. And so the plot here just shows the number of coils. This is theoretical, but the number of coils you have versus the acceleration you achieve. By theory, you can achieve acceleration as fast as the number of coils you have. So for a 4-channel coil, you can achieve a factor of 4 acceleration. That's, however, not true. Most reasonable acceleration factors are in the 2 to 4 range for SENS and GRAPPA. So I've shown you this before already, and here again are the reconstructions from the different accelerations. You can see that you can, even with this acceleration of 2.56, there's a little bit of a oval-shaped noise amplification there, and that gets accentuated as you go faster and faster. So there's no free lunch. There's always a price to pay in terms of the geometry factor for the given coils that you have. And so here are the G factor maps, and you can see again that the area corresponding to the high G factors is the area that you're unable to resolve completely. All right, so let's just look at a few more examples, and then I will wrap up. So just to remind you that noise in parallel imaging is spatially variant, and that is, again, dependent on the coil geometry. So if you ever see images that have noise amplification in the middle or an eyelid type of an artifact, like an oval-shaped eyelid artifact, you'll probably need to tone down the acceleration factor a little bit. So this is just one example with an R acceleration of 4. And again, the artifacts appear the same whether you're using image-based methods or case-based GRAPPA-based methods. Here's a little bit more obvious one where you can see there's residual aliasing left in the middle of the brain. And again, it all depends on where the coil sensitivities sit relative to the anatomy you're imaging. In the abdomen, you can see that with an R acceleration of 4, this is just way too noisy. And even with an R acceleration of 2, there's a little bit of artifact in the center. Here's another example, a 16-channel coil. You can see that we've drastically reduced the scan time here. This is actually not too bad for an R acceleration of 4, but the noise SNR is maybe a little bit too grainy here. So an acceleration factor of 2 is fine. This is a 3D volume. I'm just showing the mid-sagittal slice. I'm hitting this a little bit more. So this is when you take a coil apart, they're nothing but just coil circuits. And this was actually designed for 2 legs. So this is actually 2 cylinders. You can see where the coils are relative to the legs. And you can look at geometry factors in one direction, in the other direction, or in a 2x2 direction. And again, sometimes if you're trying to achieve acceleration, a net acceleration of 4, trying to do it in 2 dimensions is actually better. Because you can see here the maximum G factor is only about 2.5, whereas if you're trying to push it in the Z direction, the sensitivity profile isn't great in the Z direction, so you have a high G factor of 30. So just think about, depending on what coil you use, what orientation you're scanning and what axis is the best for imaging. Okay, so coming to the end, I got about maybe 10 minutes more to go. I'll look at some examples and artifacts. And again, parallel imaging, at the end of the day, all you're going to see is either residual aliasing artifacts or fold-over artifacts or SNR loss. And this is no different depending on what anatomy you're looking at. So here's an example of the heart, and this is basically subcutaneous fat that's not been reconstructed properly. And this is a misalignment between the calibration of the coils and the accelerated scan. So there's a little bit of an edge effect here. You can see there's subcutaneous fat left over in this coronal image. It's more subtle in this slice in the bottom. And this brain slice here, sagittal slice, is even more subtle. I couldn't even see it in the beginning, but you can see that the eyeball is actually here on the posterior side of the image. That's residual aliasing. There's also leftover edges here on the image, coronal image on the top. Not to sell this book or anything, but this is actually a really good book that I came across once. Yeah, I have no financial affiliations here. I just thought this was a really good book, and this was a really good diagram. And if you ever want to figure out what artifacts you have, this chart actually takes you all the different possible artifacts that you can see in image, and you can see aliasing or parallel imaging artifacts show up right on the top here. So residual alien artifacts is the most common in parallel imaging. All right, so these are kind of fun ones. So here's aliasing images. You've already seen those. Here you can see kind of the scalp of another slice wrapping in B. C is more subtle. I think Sam actually showed me this in a similar slide. This is the ear wrapping in. This is actually pretty common if you're doing sagittal slices or coronal slices and you try to reformat and you see the ear coming in. A was actually really cool. I saw this on a talk once. I thought, that was really cool. This is actually IV lines on the outside of the field of view wrapping in and unable to resolve by the coil sensitivities. And you can totally mistake this for some irregular vascular anatomy if you're not careful. More textbook examples, you see the eyelid residual aliasing here. Some people call it the hot lips. Here you can see fat wrapping in again. That's incomplete aliasing. This one on the blue background here is really subtle. I actually had to look really hard. Actually, the hand is wrapping in near the pelvis, and that's because the coils couldn't reconstruct it properly. And then there's a ghost of a kidney on the bottom example here. And more subcutaneous fat from breast tissue. And then again, you can clearly see the G factor noise amplification on the one here. I like this one. This is actually fluid in the table. It could be bodily fluid, it could be contrast, it could be saline. Technologist doesn't know about it. You go and scan, it gets picked up by the scan coil, and then it gets aliased right into the anatomy and the sensitivity profiles of the accelerated scan that is unable to completely resolve it. This very thin line here in the blue background, this is I got from one of the ISMRM talks. This thin line is actually an artifact. It's nearly impossible to see, but it ends up being, again, IV lines wrapping in, and often the coil sensitivity profiles don't pick up these IV lines. The coil actually might be sitting underneath the IV lines and the anatomy, so you never get to see them. So it's often good to just to think about where signal on the outside of the field of view may accidentally wrap in without you even knowing it. This is a breast example. This is kind of like that spine example I showed earlier. If you ever played around with these breast coils, you know that they have really good sensitivity left and right for the left and right breast, but they almost have no sensitivity in the AP direction. So if you mistakenly put the phase encoding direction or the accelerating sense direction in the AP direction, it will fail because you can see the breast that's ghosting here, the inability of the coils to resolve the aliasing. So here, by same person, same anatomy, same scan, just by changing the sense acceleration factor to left and right, you can easily do the scan without having any artifacts. So again, coil geometry is important. Um, this is EPI distortion, and you can see that this is an EPI scan for diffusion, and you can see that we see the typical distortion in the frontal lobe of the brain. And because with sense or grappa, the echo train length is much shorter, you don't have as much distortion or susceptibility. You don't completely get rid of it, but because you're spending less time in K-space acquiring data, you can minimize these artifacts. I'm going to skip this in the interest of time, but just to show you more examples of time of flight in the brain, and you can see with and without parallel imaging, even though the noise amplification is seen greater here, you can appreciate the greater details of the tumor here. More examples in the abdomen. Parallel imaging is great for the abdomen because it really prevents people from having to do long breath holds. So you can see all these, the image on the right is the parallel imaging scan, and you can see there's finer details in the structures of the liver vessels along the GI tract. Here, the outlines of the anatomy is much crisper than the original non-accelerated one, and then the breast one is very comparable in diagnostic quality. I did a lot of work in angiography. Angiography now benefits from both parallel imaging and compressed sensing, but you can see for whole body angiography with different stations, you can see that with parallel imaging, you can get just as much signal and image quality. This was using a whole body array. And one of the things you can do with the extra time is to get thinner slices. So you can hopefully appreciate that in the lower leg station here. This is a thinner slice. So you can see the vessels and the popliteal trifurcation much better than without parallel imaging. MR-venography, here you can see that comparably on the right, images with parallel imaging is almost no different than images without parallel imaging. And then one of the other kind of not well-known benefits of contrast enhanced MR angiography is if you're doing, say, angiography in the neck, a longer scan time, you often get contrast coming back in the venous, in the jugular veins. But with sense, because you're actually acquiring data faster, you actually can almost nearly bypass the venous phase. So no venous signal gets encoded into K-space and you have less contamination. So that's kind of a side benefit. I'm going to skip this in the interest of time. So just to remember, parallel imaging MRI signal is received simultaneously by multiple receiver coils. Each coil has spatially varying sensitivity. That's important. You need to know where that spatially varying sensitivity is, because if you do, then you can design your phase encoding acceleration properly so you don't get the reconstruction artifacts. This is also a really good book, almost written 10, 15 years ago. So it's probably a little bit outdated, but it covers everything with parallel imaging at that time. And you can see all the different red circles here that are the benefits of parallel imaging. I think I've touched on almost all of them. The one I didn't touch on, I don't have data myself because I don't have a 7 Tesla scanner, but I've seen people who have done it. It's because if you're using parallel imaging and you're having shorter echo trains, especially in a fast spin echo sequence with a lot of 180-degree RF pulses, if the echo train is much shorter, then you don't have such an issue with SAR or patient heating. So that's another trade-off or beneficial trade-off of parallel imaging. Okay, so I won't read this again, but this just reminds you of the take-home messages that I tried to show you. Hopefully now things are a little bit more clear with how parallel imaging has nearly revolutionized MRI. And with that, I'll thank you for your attention. My email is there again if you have any questions. Happy to take any now or later, and thank you.